effects that moral injury has on the people who suffer from it. Scenario one is the COVID pandemic. The COVID pandemic was a slow motion mass casualty event. As of November 1st, over 29 million cases had been diagnosed and 6.58 million deaths had been recorded worldwide. The battle against COVID intensified the emotional stress that many licensed healthcare professionals faced on a daily basis from the multiple demands of them, including their time, energy, and attention. These people dedicated to comforting and healing the ill and injured perceived the otherwise unnecessary suffering and death of their patients as serious personal failures. I have got a cat who just decided to come in here. When hospitals became so overwhelmed that they had to initiate what we call crisis protocols, physicians were forced to decide who might live and who would surely die. And this is a type of triage that clashed with their training and professional beliefs. The result was an emotional trauma. Like burn wounds, emotional trauma is dose, duration, and extent dependent. The more intense the exposure to the trauma, that is the dose, the longer it lasts, that is the duration of time you have to deal with it, and the more areas of life it affects, which is the extent, the greater the damage. The pandemic was like a hot stove that burned our sense of self-worth. The gap between what we know to be right and true and the reality of what we're actually doing and seeing results in something called cognitive dissonance, where you're fractured between what you believe and what you see. Deep or persistent cognitive dissonance can lead to moral injury. This was initially recognized in active duty military and veterans of war, as well as people in other situations in war zones. A moral injury may contribute to an overlap of professional burnout and post-traumatic stress disorder, but there are differences. Burnout is essentially a result of structural factors within the work environment, which create high demand, accompanied by low levels of autonomy and control. Over time, burnout can occur. However, unlike moral injury, when the practice environment improves, so does the sense of burnout. PTSD, on the other hand, is a memory disorder, but it's one that's flipped on its head. It prevents sufferers from forgetting past traumatic events. When presented with certain internal or external stimuli, the sufferer re-experiences the trauma. This would include rapid heartbeat, intense fear, and even physical aggression. By contrast, moral injury is a deep, long-lasting form of suffering characterized by unmitigated and undeserved shame and self-recrimination. As Rita Nakashima Brooks said very eloquently, moral injury is an affliction of moral conscience, a negative judgment we pass upon ourselves in response to violating our core moral values or from being contaminated by exposure to evil. It can lead us to feel unforgivable for something we did, failed to do, witnessed, or endured. And it can cause us to conclude that we are no longer good and decent persons. Please forgive me here. I am myself recovering from COVID and my voice is lagging behind. One of the earliest casualties on the frontiers of the COVID pandemic was Dr. Lorna Breen. Breen was a very accomplished and dedicated emergency physician. After recovering from COVID herself, she struggled to uphold her professional standards in the midst of organizational chaos. Caught in a downward spiral of exhaustion, disillusionment, helplessness, and shame, on April 26th of 2020, Dr. Breen took her own life. Scenario number 2, war, famine, and natural disaster. Healthcare professionals and allied staff in non-governmental organizations, NGOs, had the same challenges that frontline workers on the pandemic faced, though in a more dangerous environment with less sophisticated equipment and often a paucity, a lack of life-saving medications and just basic interventions like intravenous fluids. While the main focus of humanitarian work is saving lives, alleviating suffering is also a high priority. However, NGOs often lack palliative medications like morphine, as well as the time and opportunity to comfort people who are frightened and dying and their families. Comfort care may seem like a luxury in the midst of war and national disaster, but watching somebody suffer unnecessarily is inherently traumatic. For many healthcare workers and NGOs, the distress doesn't end when the mission ends. In fact, emotions may not surface until well after deployment. In 2019, Dr. Thomas Kirsch, an emergency physician and expert in disease management, wrote an impassioned article in the Washington Post about working in Haiti at the time of the earthquake that killed over 200,000 people. He writes, "We are trained to take care of everyone. It is our moral duty to do what's best for each and every patient we see. Nobody dies until we have tried everything. That's how I was taught. That's how I practiced. But it wasn't like that after the earthquake. We couldn't treat everyone. Some just died." A recurrent criticism of NGOs is that they don't sufficiently address the emotional needs of their workers while they're actively serving and after returning to civilian life. This deficiency contributes to compassion fatigue, disillusionment, and cynicism, which can ultimately lead to moral injury. There's also, of course, a high rate of PTSD among those workers. How am I doing for time here? Am I good? Okay. Scenario number 3. This is a new one. I hadn't expected it. Abortion bans. Any circumstance that prevents healthcare workers from meeting their professional obligations can contribute to moral injury. This is especially true if the impediment is arbitrary and entirely avoidable. On June 24th of this year, the US Supreme Court issued the Dobbs decision, which struck down Roe v. Wade. Roe v. Wade was the decision that for almost 50 years gave women the constitutional right to reproductive autonomy, including abortion up to 28 weeks gestation. When Roe was struck down, the entire healthcare system was thrown into chaos. Following Dobbs, in states where abortion bans came into effect or were imminent, the only exceptions to abortion was protecting the life of the mother. Since the procedures for performing elective abortions are essentially the same as those for treating such complications as prolonged bleeding, incomplete abortion, fetal demise, and uterine infection, the new bans create a substantial legal peril for providers and dangerous delays in treatment for patients. Until recently in the US, and this is just an example of one problem that US healthcare providers are now facing who treat pregnant women. Until recently in the US, treatment of ectopic pregnancy was considered a surgical resection, not an abortion. Untreated ectopic pregnancies usually result in maternal death, and even if a woman survives, the pregnancy almost never comes to term. Occasionally, an abdominal pregnancy will come to like 7 months or so, but it's very precarious, and it ultimately requires surgical removal of the fetus. If abortion is banned at conception, which some lawmakers are considering doing, resecting an ectopic embryo could be considered tantamount to infanticide. Now think about that. To treat an ectopic pregnancy, a person might be criminally charged with murder. There are other unintended consequences. Physicians who work in states where abortion is still legal are often overwhelmed by patients in nearby states where abortions are banned. One physician, Dr. Allie Linton, who works in Wisconsin, where, and I kid you not, an archaic 1749 law that forbids abortion was resurrected after Dodd's came into being. She told CNBC, "It's heartbreaking because restricting access to safe abortion is going to push people to make incredibly dangerous decisions medically." I started medical treatment in 1983, and even about 7 years before abortion became legal in the US, we were still seeing patients coming into the ER having tried to abort themselves with knitting needles and crochet needles and back alley abortions. It's because they were available legally, but just not within the reach of some people. There's another unintended consequence. I'm sorry. It's just a matter of time before a woman whose medical abortion has been delayed or denied will die as a result. There have been a number of well-publicized cases in other countries. Most recently, I think people might have heard that in Ireland, where a woman died because she was refused an abortion. And subsequently in Ireland, they completely changed their laws to allow legal abortion up to the time of quickening. Avoidable deaths that occur during pregnancy create particular distress because in this case, at least 2 lives are lost. And this is a prime example of moral injury. Scenario number 4, professional license discipline. Moral injury can contribute to agitation, despondency, substance abuse, and even self-harm. Unfortunately, the culture of medicine tends to view these conditions as personal failings that lead directly to professional impairment and patient harm, rather than as symptoms of emotional distress that are amenable to treatment and oversight. The US medical licensing system, for example, often treats licensed medical care professionals that have substance abuse or mental health disorders with contempt rather than compassion. In addition to conflating emotional distress with professional impairment, they also tend to equate substance abuse of any kind, even if you're drinking 2 or 3 beers a day to cope with the stresses at work. They will compare it with addiction. They leverage their power over practitioners' licenses to coerce them into scientifically unsound, overreaching, and extensive disciplinary programs rather than individualized treatment protocols that promote both recovery and ensure patient safety. And this is a distinct violation of the Americans with Disabilities Act, which requires that patients are always treated confidentially and with individually devised treatment plans. And ironically, this approach to discipline can worsen pre-existing mental health problems and add to moral injury. This has led to suicides. One well-known case is that of Gregory Madej, a brilliant and well-respected clinician who, after relapsing into alcohol use, took his own life rather than repeat his board's onerous 5-year disciplinary program. Review of the literature demonstrates that the United States is not alone in its punitive attitude towards healthcare professionals with emotional distress. Great Britain, Norway, and other European countries also tend to stigmatize mental illness. A study from the Indian Journal of Psychological Medicine by Musasamy et al. Concluded that the stigma of mental illness causes significant harm to medical practitioners in all specialties. Summary. The practice of medicine is inherently stressful regardless of one's field of expertise or practice venue. Anxiety, depression, insomnia, and self-medication are common conditions that transcend culture, country, circumstance, and system of payment for services. Whenever the professional demands of an environment exceed the ability of conscientious individuals to deliver what they consider exemplary services, they will experience psychological distress. Unrelenting and pervasive psychological distress can lead to burnout and ultimately to moral injury. And as we've seen, and as we're aware, it can also lead to suicide if left ignored and untreated. Because of the professional stigma and fear of loss of stature, healthcare professionals who suffer from psychological disorders are often reluctant to seek treatment. And this can lead to unnecessary suffering, and as I've said before, even suicide. And this is kind of an amazing statistic here. In the US, the majority of physicians who took their own lives were not getting any formal psychiatric treatment at the time of their deaths. We can be our own worst enemies. Our failure to live up to our own expectations can lead to shame and self-recrimination. When we feel shame, we tend to isolate ourselves. Isolation contributes to the moral injury. I encourage everyone who is experiencing any kind of psychiatric problems, including those that might have arisen from moral injury, burnout, and PTSD, to please seek psychiatric care, either individual treatment, group treatment, or even meditation and other modalities. It's also very, very important that people reach out to their colleagues and their friends and get support. It can be life-saving. Also, writing about our personal experiences in a blog, a journal, or a formal article can help us process our thoughts and feelings. We must always remind ourselves that we are capable of transcending moral injury, just as we have transcended many other challenges in our lives. On a personal note, I will mention several actions that specifically helped me deal with and heal from moral injury. They included reaching out to others and discovering that I'm not alone, supporting others in their journey of healing, writing about my personal journey, and forgiving myself for being human. And that was probably the most difficult thing of all. Thank you very much for your time. I will end this.
Thank you so much for that excellent presentation. I know we have learned a lot from that. It's a real thing, what happens and what happened.